Well, we have about 15 minutes. Do we want to just go around and briefly say like where you are in the world and what your interest is in the research committee? Gwendolyn, you're on the top of my screen, so I'll start with you.
Hi, everyone. I'm Gwen Quinn from NYU. And my research is in training and communication skills and improving communication between clinicians and patients and reproductive health.
Very cool. Tyler, do you want to go next?
Sure. My name's Tyler Kettrell. I'm at the University of Washington and Seattle Children's Hospital. I am interested in understanding impacts of cancer-directed therapy and other gonadotoxic agents on late effects and family building outcomes, and so the data collection and data structure.
All right, Melina?
Sure. I'm a pediatric endocrinologist by training. I work at Nationwide Children's in Columbus, Ohio, and most of my research focuses on counseling, communication, decision-making across pediatric populations at risk for future fertility impairment, including cancer and sickle cell disease and other conditions.
All right, Evelyn.
Good morning, everybody. My name is Evelyn Lorena Carey. I'm a PhD, and I work at University of Colorado with Dr. Leslie at PIA. I'm currently not performing any research because I'm also an embryologist, but I'm very interested in vitro maturation as well as ovarian tissue crop preservation and how we can support our patient population that undergo cancer treatment.
Mm-hmm. And Heather.
Oh, hi. Hey, I'm Heather Stoney. Sorry. I'm a nurse practitioner at Texas Children's Hospital. And, I just kind of wanted to listen to see kind of what was going on with research. And we do a lot of OTC, and we send our kids for TTC and just kind of how to, we have a lot of, we work with a group, an REI group within our hospital, and so just kind of get to see what your group is doing and how we can kind of plug ourselves in.
Okay, great. Then I'm Maggie Dwyer at the Washington University in St. Louis, and I would say it's not really research, but I'm really quite interested in advocacy and making fertility preservation options more available to the population, but then also understanding, kind of like what I was saying, what population is choosing this option. Is there a group of people that we're missing, and what we can do to better bridge the gap? Yeah. So are there any thoughts? I know one thing that Dr. Gomez-Lobo, who is on vacation right now, was really interested in is this tissue bank is very, very, very exciting. So we have just tons and tons of tissue, tons and tons of collaboration amongst a number of groups. And we're now able to do this really basic science research on ovaries. So is there anybody who has ideas about what like priorities should be regarding tissue research, or thoughts? I didn't really hear a lot of basic science backgrounds.
Well, I can pinpoint in there with some ideas probably. I think that one of the most exciting things is, and that we all know, is that the ovarian reserve starts with primordial follicles. And the fact that when we remove a piece of tissue, the cortex, from the ovary and freeze it, we lose a lot of primordial follicles. And also when we thaw them. So the question is, why are we losing them? It's really not that the HIPPO axis is broken. Is it because a lot of people, there is some people who think that there is like the ovary, the cortex is very tough, and so do we need markers to double check how many primordial follicles we get when we like tell these pieces of cortex, how can we estimate, I mean, just thinking in the future, you know, how many cycles a woman can have from a piece of tissue of this cortex, you know. There is many different markers for primary follicles. I specifically don't know which one we can use at the moment, but if we use a marker, and we will need to pretty much kill the tissue. So we want to use a marker that we can be used alive and wash it off, which is very difficult. Some people use neutral red to count primary follicles.
And they use what?
Neutral red is a staining technique. Other people do slices of the ovarian tissue cortex and try to estimate the population of follicles as well. But yeah, that's just my background from my PhD. But exactly what are we looking at is the question. What do we want to be focused on? Because it's also known that these pieces of tissue will support also estrogen release, which will impact women's health in a good way. So my question is, what will be the goal if we start doing some research in these pieces of cortex?
That is such an interesting question. I love that. Because I think a goal of predicting the reserve of the cortex, that's an awesome goal. And then like what can we use as a marker? That is really quite interesting. And I know that they are considering keeping more tissue, and if there's an ability to do it, because the cortex isn't the part of the ovary that's probably important, or else it would only be cortex. And so that's another thought, is what other areas of the ovary are important for these primordial follicles, and what can you add, or what kind of tissue can you keep with them that would support developing follicles. This is very, very interesting. I like that. Are you doing any current research in this sort of thing?
Unfortunately, no. I am 80% clinical and 20% research. So depending of the needs that we have in the IVF lab, I can or cannot do some research at the moment. But that's kind of like one of the ideas that I have like in my mind. The other idea is that usually when we receive a piece of tissue, we also can get different follicles because the cortex is usually where the primary follicles are. And we can like induce in vitro maturation as well, and probably freeze those oocytes whenever they make it to M2 and they're mature for the future, you know, because usually ovarian stimulation happens and it's for 14 days. But if we can mature in vitro those follicles and make it be mature to M2, it will be a good way for the patients to have support, especially because ovarian stimulation is very expensive, you know, and also because these cases happen really fast. So we have to move fast, get the ovaries, we get the ovaries, and then isolate these follicles that we could potentially culture in vitro.
Interesting. All right. Anybody else have thoughts about the tissue bank? All right. So in the last 5 minutes, what about other thoughts about?
Sorry, I had one thought.
Oh, yeah.
I was not muted. I've been thinking about this for a while. So at Seattle Children's, we have a kind of universal biobanking protocol that all of our patients with an oncologic diagnosis are enrolled in, and allows us to hold on to any tissue that would otherwise be discarded blood, CSF. And it's part of our agreement originally with UPMC, but also with Seattle Reproductive Medicine, who processes our ovarian tissue. Any tissue that's not being frozen down, we have the opportunity to bank and store and use. And so we haven't currently had any, you know, scientific, you know, anyone that like really had a question or a way, you know, a need for this tissue. But I think we could definitely contribute to that if we had a protocol, or, you know, there was a desire to use this tissue. And so, you know, obviously the patients is already completed and it would be identified, and we could obviously provide, you know, prior treatment exposure data. I think the second part to that would be just working on an MTA to, you know, whoever would be using it. But that's definitely something that we could contribute tissue to if needed. You know, it'd obviously be like, you know, mostly just the medullary part of the ovary. But that's just one aspect. And one of the questions I've also thought about that is there would it be at all helpful in some of these populations that we don't have a lot of data, like neuroblastoma or Ewing sarcoma, to essentially try to flow or do some sort of testing to look for minimal residual disease or small molecule, you know, small amounts of disease, just to help us guide, you know, at different points in time in therapy when the ovary is collected, is there more or less, you know, potentially malignant cells in the tissue?
Mhm. That's a concern. Is there a residual malignancy? So that would be really interesting too. I love that.
I was also just going to ask in general if you knew more about the clinical populations that we have that are represented in this tissue bank, and are there populations where there's just not a lot of data out there? Because I mean, I obviously have my clinical research hat on, but I feel like for the past few years, at least in the PAC, we've been talking about how, you know, ASRM has this guidance, but we can't really like use that guideline necessarily as an umbrella guideline for all of our pediatric populations. And so are there questions that we can answer because of the populations that are represented in that bank?
Well, I have to admit, I don't know what populations are most represented, but I do know that initially until 2021, a portion of all tissue was going to research. And so it should be a fairly representative mix of who is getting OTC. But that leads back to like the thing that I'm interested in is who is getting OTC and are we missing that population anyway? So this actually could kind of support it. Like what kind of tissue do we have and who is missing?
Yeah, and if we could better characterize that, you know, well, who is missing, but if we could better characterize who's there, then we can think about more specific questions we could ask in, you know, that are relevant to those populations, so we can give more tailored guidance to certain populations.
Yeah, very interesting. Okay. All right, I love these ideas.
Because I have another meeting.
Yeah.
In just 2 minutes.
Well, I think, are we supposed to get back together? Are we supposed to leave?
No, I think we're dismissing.
No, we're all done.
Here.
Oh. Does anybody else have any other thoughts?
Not
Well,
related to the basic science portion of
Yeah.
it, but I'm curious on the various ways that people are successful in having this covered by insurance directly, or because they're wrapping it into another surgery.
Yeah. This is kind of
Including
like always
storage.
this is like always a big thought because I think it varies state by state. You know, and some states are more likely to pay for the procedure. And I feel like we reported on our patients in DC and it was like all but one were covered. And then I came here to Missouri and it's like 50% are covered. You know, and so what is the difference? And is it just insurance difference? Is it the patient population? Is it the way that we're like collaborating on the procedure? I'm not actually that sure, but it would be really interesting to kind of do a pulse check again to see what because we've published on it before, but see what the current status is after the ASRM came out with their guidelines, and then also just the changing insurance landscape for reproductive health. Yeah, I'm gonna write this down too.
Yeah, the insurance landscape is very interesting. In Washington State, we're able to get OTC covered for minors, but we are not able to get oocyte cryo covered, which really doesn't make any sense. But and it's all, but we've never had anything, but we have gone through a different mechanism, which is the early prevention and screening of treatment and diseases program, which says if you screen for a disease, then you have to provide all the coverage for it. And in that bill, we got, or in that policy, we got written that ovarian tissue cryopreservation is part of cancer therapy and fertility treatment. And so but they specifically didn't include oocyte cryo. So it's very crazy.
So interesting. That goes back to like advocacy and policy too, right? It just,
yeah.
It's just a lot. Because I know in Kentucky, what we did when I was there, we went into the Kentucky insurances, and we lobbied them to cover the procedures. And then when they said they would, then private insurances kind of followed suit, and then eventually the laws changed. But that was like where it was started. And in Missouri, they are uninterested in letting me lobby them. Like the Missouri government insurance. They're just like, no, we're fine. We'll talk to you about this.
Yeah. It's very interesting. I think the other interesting question on that is, as we look at like the political landscape as well, as like what's getting passed and what isn't, are like comprehensive infertility bills with fertility added on. Are those being more successful, or are fertility preservation standalone bills more succable? And what does that look like?
Yeah, I mean, to your point, also the carve out, I guess is the best word, or the disallowance of embryos, which is potentially discriminatory towards females who are diagnosed. I know we're talking about pediatrics and adolescents here, but you know, females diagnosed into their late 30s, the inability to have embryos covered.
Well, this actually might be that part, the bills part actually might be something we could work on with collaboration with the Alliance for Fertility Preservation, because they are so knowledgeable about the bills. So we could say, like, what are the bills? What is more successful? Is there a difference between state? Is there a difference between comprehensive FP bills just being bundled in with, like in Illinois, what we did was we just bundled it in with the they already had insurance mandated coverage for fertility treatments. We just bundled that in. And then, like, again, in Kentucky, it was its own little standalone thing. That would be really interesting.
Yeah, and you know, Joyce Reinecke, I'm not sure if she's presenting at the conference, but she tends to have all that information at her fingertips.
She's such a good researcher. She almost always presents. Okay, very cool. All right, well, these are some great thoughts. I think this was fun. Well, thank you. Bye, Tyler. Anything else you wanted to touch on before we call it a day?
Thank you.
Okay, well, I will send out
everyone.
those things. Yep, and you let me know if you want to participate. It'll probably be a little bit. I'll wait till Dr. Gomez-Lobo comes back from vacation. I'll talk with her, and then maybe we can collaborate and see if we want to get some of these projects rolling.
Okay.
All right. Well, it's nice to meet you all.
Bye-bye.
Okay.
Thank you so much. Nice to meet you all. Bye-bye.